Hello, everybody. My name is Tomas, and I'm from Oscar Senior, a company which is focusing on the senior care, on digital senior care all around the world. Today, I would like to talk to you about remote care solution for people with disability and older adults, how we can support them with the technology and how the care itself might be easier and more efficient with them. But let me get started with that, that remote care and remote support service are relatively new in terms of how the care is provided. And from our experience, many companies or many providers are a little bit struggling with the technology and are afraid of using a technology towards their clients or seniors or whatever disability people. The point here is that they cannot be, because as the population is aging, many people, many elderly people are getting more tech savvy. So from that perspective, having remote support service on a distance is something which is relatively fine, and people are actually like with that. In general, our main issue globally is that population is aging, and it's everywhere. We understand it in China, we understand it in Hong Kong, we understand it in Europe or in the United States. The point here is that there is not enough caregivers to support all aging people. And so the trend is, and whatever people actually like it, they would like to stay at home. And so they want to be supported in their homes. And so the care is actually should be provided remotely, unless, of course, the conditions will change and people will get a little bit, in different type of conditions, and so the care has to be provided in person. But it's a different story then. Nowadays, limitations of providing care or relevant care is that there are not enough people, of course, which can provide the care. The care is provided either in senior homes or senior facilities or some kind of special facilities for people with disabilities. However, of course, not all which are required to be care of can be members of the facilities. And so home care service is as one of the part of the provided care is or could be the way. However, there is also not enough people, of course. Another thing is the fear of technology. There are a lot of care providers which are simply afraid of technology because they think, the technology doesn't help. We are doing our stuff as we know for years. We are fine with that, and we understand that, and it's okay. However, time is changing, and also people which are coming into age where they might need some kind of care are fine with technology. So in that sense, technology can help. And I'm not talking about only the technology like of the connection, but I will be also talking about other options which you have with which technology brings to your hands. And last but not least, is difficult communication. What does it mean? That if the people are, for example, at their homes, they might have an issues to get in touch with their caregivers or get with their families, etc. World is getting smaller, and a lot of elderly people, a lot of people with disabilities, their relatives are, far away or different time zones, and so it's getting more complicated to get in touch with them. The technology can help in variety of fields in how the care is provided. and it's always should be tailored for those specific needs. So there are, for example, home care agencies which needs to provide with, for example, communication, but there might be also other senior communities where you want to support with the technology, you want to support some kind of other activities or social events, etc. So all these, let's say, types of care provided have a little bit different requirements, but in general, we can still talk about the remote care technology. And so this remote care technology can support them and can help them narrow down the provided care. The benefits, if we were talking about the remote care technology, the benefits, there are many of them. Of course, we do not want to exchange or replace the one-to-one in-person meetings, etc. But the technology can support the existing provided care, and that's in that sense. That means that some stuff could be replaced, and the quality in general increased. So besides all these communication capabilities, you can also reduce the cost, because if you don't have enough, for example, manpower to provide a care, you can simply exchange some touch points with the remote care, and then you can reduce the cost. Seniors or people with disabilities have the options also use the technology, not only for the remote care, but also, for example, to be in touch with their families, and or just to have a fun, just something like simply be online. You can prolong, and which is some kind of actually social pressure, you can prolong their stay in their homes. So that means that they cannot move to the facilities because they don't need that at that time, and they are still feel independent. And it's also the part of some kind of physical status. So it's very important for many people which are afraid to be moved somewhere else, because then it means something wrong, right? With the technology, you get a set of the tools which can really be tailored to support aging in place, support independence, avoid isolations, and there are many different factors. So as some kind of examples, you can share documents with not only with your clients or your patients, but also with the family members. You can make video calls. You can make a group video calls, so the people can communicate among each other. So you're actually supporting some kind of socialization, and you can also save time by to actually decrease the personal visits. You can save a cost, and you can enrich service offerings to make it easier and keep people age in place. There are many different, if I would be specific, there are many different ways how you can really support those individuals. And if I'm talking about individuals, what I mean, the technology has to support also like individual way of how the care is provided. So what I mean is that the care is not provided to variety or to all of your clients, for example, but different clients with different needs might have a different view on that technology. And if we are talking about different view and features which are there, we can talk about check-ins, remote check-ins. We can talk about the communication. We can talk about connections with the family, family reminders, pills reminders, telemedicine, and many others aspects, and many others ways how the care is provided, or what type of the care is provided over here. Generally, this technology can really individually talk to individual person. in general, if we would be talking about the individual person, there are two key, let's say, parts of every technology, which I mean the technology care. It's you as a care provider, for example, and then of course the client or the senior or the person with disability. However, you can also connect the family, and in that sense, if those people are all connected, the care is not only provided from you towards the client, but it's also provided from family to client, because that part of connection is important for many people, that they are staying in the loop, and they are simply playing a role in their life, right? So you can have an active communication or passive communication with the client, but they can have a similar stuff with their family. And so you are not only getting the automatic information from the senior, from the client, but you can also be more active in that sense. And at the same time, the senior can be really in touch with people, with their families, and also with the people all around them. What are the key factors? What would be also understood as a key factors in terms of the technology which is provided for the support remote care, is that it should be some kind of open platform. Open platform means that since we are talking about the individuals and the care is not similar for everybody, that means that all these let's say features should be tailored to every individual, and on a simple way. And that means that you are able to really customize an interface, for example, to every individual very easily. It should be also device agnostic, because there are many individuals which are using smartphones, but there are others which are using tablets or computers, etc. So you all want to have them integrated. You don't want to provide them additional, let's say, medical device or something else, which they might be afraid of, but they have something in their hands already. Or you can provide them something which is relatively common, and so they can easily get connected, and you can easily start providing the care. And last but not least, it's a customization. Customization really follows individual requirements in that sense. So as was mentioned at the very beginning, remote care agencies or senior home facilities, they have a different needs, and all these has to be also customized from let's say high level perspective, and then also the clients will get the right content and right features. If I can share with you, I would like to share with you actually two case studies, two case studies which are talking about how simply can be remote senior care provided. The first one from Comfort Assisting. It's a US-based California home care agency, home health agency, which provides care to hundreds of individuals all around the San Francisco Bay Area. And these individuals are they live in their homes, so they are visiting them almost daily, or they have some kind of schedule set up with them. With the technology and with the remote care, we integrated into them into that environment. They actually have been able to decrease the visits of 19%. That means that almost one-fifth of the time can be now distributed to people which really needs to that service. And It was because there were a lot of visits which took less than 15 minutes. Those visits were about like medication check, or how are you doing? Do you need anything? Okay, provide me with your shopping list, and I will help you to get shopping, etc. So all these type of services can now, or has been transformed to remote care, and from that perspective, it's more efficient. And of course, the time which caregivers spend travel on all those visits were also decreased by 20%, which is significant, because they now have more time to focus what really matters. And of course, if we are talking about money, you can imagine that if 20% of daily time is spent by traveling, you won't really focus on your work, right? The second case study is from the ARC of Prince George County. It's also US based, from Washington area, and this company, this provider is focusing on people with disabilities, and they focus, or they set up the environment for these people for the remote video and remote video check-in. They also have auto answer video calls, which also gives them an opportunity to get connected, even those people are not able to turn on the video or so. And these video sessions are used daily. There are hundreds of calls, by the way, every day. And they can also set up the group sessions. Before that, they has to be able to transport all these people to one place and provide whatever content on one place, which is on one hand some kind of socialization as well. However, it was super time consuming, and they were only able to do it once a month, right? Nowadays they can do it almost daily, which is significant difference, and they really love it. All right, that's it for now. My name is Tomas. If you will have any more questions, of course, I'm happy to answer, and I'll be happy to be in touch with you. Thank you very much.
Thank you, Thomas, for the sharing. And just to let our audience know that Thomas has generously shared more information on his platform with us in his PowerPoint slides. So you may download the file to take a look. And besides, we are very happy to have Thomas here with us for the live Q&A section. Hello, Thomas.
Hello, everybody.
I'm very happy that you are taking your time to here with us to answer some of our questions. So let's take a look of our question asked by the audience. The first question is, besides the support to older adults at home, how would see the potential of remote technology in empowering them to stay active and healthy?
That's a very good question, by the way. What we see as a trend all around the world is that all people, these aging people, want to live back their homes. So aging, care itself somehow needs to be provided remotely, because these people simply want to enjoy their lives as much as possible. So in general, from our perspective, remote care supports the individual lives, and so they can continue as they were before, and this is good. This is good for health. This is good for everybody, by the way.
Yeah, I see. And here we have another question for you. So how would you enable a high customizable interface for individual seniors? Would that be costly? How the service provider see the cost effectiveness or return on investment?
Well, in our platform, it's very simple. You can customize it with few clicks. So you don't need to understand any programming, etc., because it's very user friendly. So what we know from the market and from our existing customers they can tailor it directly to every single individual in few minutes or few seconds, actually, as well as they can, for example, have specific groups with specific interest, so they can customize the interface and features available for them for the specific group, even the individual. So it's very simple, doesn't cost anything, it's included into the platform.
It's good to hear that it is actually very user-friendly, so that it will make it more accessible to everybody.
Yeah, exactly. This is key. And by the way, there are like two parts. Of course, user friendliness for the caregivers, for those who are managing the platform, but most importantly, maybe a user friendly for the aging people, for seniors, for those who might not understand the technology, and this is crucial.
Yeah, I agree with you. So here comes another question. Would you please elaborate more of your company's device or system, how to apply it in an elderly's home and care agency, and the customization?
Oh, that's also a very good question. Our platform doesn't need any kind of specific or special requirements. It's a software platform, and it works on any kind of available device. Device, I mean tablets or smartphones. Tablets are, by the way, more efficient because simply a bigger screen, and it's more convenient for people who are presenting or who are working with the platform. So you don't need anything special. You just need to have devices which we can help you also to order, and the installation, or actually the uploading the system, the platform to the device. It might go automatically because we have a process which install the system, as well as, for example, security controls, etc., into the device. So it's pretty simple, and you don't need any kind of specific or technical department or so.
Wow, that's great. So here comes another questions. Our audience asks, remote service is all very good, but without human touch, it could still be harmful for their psychology. So how do you strike a balance?
That's absolutely a great question. Our goal with the technology is not, of course, to exchange the personal touch with the technology. That's not the point. The point is, we understand that as we are aging as a population, and there are more and more people, and less caregivers, all those people who can take care, the technology can support that personal touch. So we are not saying that, okay, you have to remove the personal touch and now focus on technology. No, the technology somehow just supports what you already do, and also help those elderly people to really age at home and enjoy their lives. So even they want to have the personal touch. So maybe every single provider can consider if the personal touch is, let's say, needed every single day with that specific person, or twice a week or something like that. But the technology can support the other stuff, because we are also in touch now in person at the moment, and even we are using the technology. So this is somehow like a balance which every single provider can find. And this is why, by the way, the platform is fully customizable, because every provider might have a little bit different needs in terms of personal touch. So that's the point.
Yeah, I think your answer is a very good reminder to us as a service provider. And here comes another question. Our audience asks, you mentioned fear of technology is one of the limitations to provide relevant care. Then any recommendations for you when you promote it to the elderly or carers?
Yeah, I'm also getting that older, by the way, and I'm not sure if you know that feeling. If you get something which is relatively new or innovative, and you are somehow you get struggling with, hey, how does it work? What is it? What does it mean? 10, 15 years ago, I was like, okay, it was all common. So we understand that even we we are aging, and people who already entered that age where they need some kind of support, they might be tech savvy, they might not, of course. However, there is a gap between technology which is available on the market and their understanding, which is pretty normal. This is not something unusual. So that's why the interface itself is super simple. And however, if you want to provide even more, let's say, functions and features, etc., for those who are tech savvy, you still can. I mean, it could be super simple even for those who are absolutely not tech savvy, as for those which are really like technological people. So few years ago, we had a little bit different issues. If I'm talking about issues, I mean challenges for those who, for people which we are approached. Nowadays, it's even different, and it's going to be more different in 5-10 years, because again, we live in technology, so we are getting more and more. It's getting more and more common, and so we, with Oscar Senior, we try to follow that path, because we can now allow to even add more stuff, and it would be slightly more complicated in that sense. But for those who are tech savvy, it's pretty normal. It's not a big deal.
I see. Okay. And Thomas, I think it's almost time. So thank you very much for taking your time here with us and answering so many meaningful questions, providing so many great recommendations to us. Thank you very much.
Thank you very much for you.
Thank you. Goodbye.
Well, thank you. It's a great privilege and pleasure to contribute to the GIES summit in Hong Kong. Hong Kong is a place which is very fond memories for me, having been many times since the 1980s. And in particular, I had the privilege of working with the Hong Kong administration in the early 2000s around developing plans for intermediate care services in Hong Kong. I led these developments in the UK at the time, and the greatest success with deployment of integrated care services, intermediate care services that were founded on principles of integrated care, was in Hong Kong, successfully implemented, making a huge difference to what was called bed blocking, but making sure that older people were cared for in the right place and the right time. And I'm proud of that achievement. I'm proud of working with many colleagues in Hong Kong to get there. So it is such a pleasure to re-engage with colleagues in Hong Kong today and talk about facilitating integrated care with digitized assessment and analytics. Slightly dry title, but the excitement I feel about this relates to the opportunity to break the mold in the way we deliver care to older people in 3 ways. Break the mold through addressing the things which really matter to older people and making a big difference in their lives. Most importantly, breaking the mold in the way that our system helps promote healthy aging, helps compress morbidity, reducing the costs of long-term care and creating a sustainable system with an aging population. And breaking the mold through deployment of digitized technologies for information sharing at both individual and population level, based on the things which really matter to older people. My interest in this area, and indeed my whole career in the care of older people, was sparked by my mentor, Jimmy Williamson, Professor of Geriatrics in Edinburgh, whom I met first as a medical student, and then he mentored me through my early career. Jimmy broke the mold. He got his consultants to drive red sports cars, so when there was a crisis for an older person at home, the general practitioner could phone the hospital, and whichever consultant was on rota would drop what they were doing, go in the red sports car out to the older person's home. And Jimmy was teaching the dynamic of timely assessment and intervention through a very visual model. I also was in Beijing a few years ago to meet the first 22 Chinese geriatricians, all of whom had undertaken research fellowships at Johns Hopkins University, but they were practicing Scottish geriatrics because Jimmy had taught Johns Hopkins. So his reach was huge. And when Jimmy retired, he asked me to solve a problem which he had identified. And the problem was the unreported needs of old people, that 2/3 of the things which really matter to older people for their health, their independence, their well-being go unreported and therefore not addressed. And I've spent then many years, over 30 years, working with colleagues across the world on a model to identify the things that are important to older people and then connect older people to support to address these things. And in 2018, 5 years ago, I set up Care Technologies to provide a business model to get this method to scale with an ambition to reach 100 million older people globally with this methodology by 2030. So that's my background, inspiration, and ambition for work in this area. I'm very pleased that through Care Technology, we've developed a digitized method which won the inaugural 2021 United Nations Prize for Digital Innovation for Healthy Aging. And the tool has been identified as unique in providing a valid method for use across the world to have a structured conversation with an older person which identifies the things that matter to them and then connects them to support to address their needs. The tool can fit within a suite of other tools. It feeds World Health Organization ICOPE pathways, something some of you might have heard of, Integrated Care for Older People's program of the World Health Organization. And it also can feed clinical pathways for frailty, for falls, for cognitive impairment, and it can generate a screening tool for resource allocation purposes relating to the needs for social care and support. And we're working actively with colleagues in all World Health Organization regions. We've got a big group in China. I would love to get something going again in Hong Kong. We don't have active work in Hong Kong yet, but perhaps after the seminar, we will set something up with you. And the tool is available in all major languages around the world. This is how it works. It has to be locally adapted. Older people live within complex systems of care, and older people themselves have complex needs. So we have a staged process to implement to get the benefits from the use of the tool. First, we have to agree how we're going to identify older people, and generally these are people 75 and above living at home, or less than 75 who have indices of socioeconomic deprivation, where a targeted approach is beneficial to them. Can also be older people who are already in contact with domiciliary services. The tool itself collects personal details information and then covers a structured assessment around 6 domains of need: looking after yourself, getting around, your safety and relationships, your accommodation and finances, your mental health and well-being, and staying healthy. And there's a total of 56 concerns which are really important to identify and respond to where it's a priority for the older person. How do we respond to these needs? We provide 4 connect channels. One is to nationally curated information resources to help the older person with self-management. We agree services which we can signpost the older person to based on where they have a priority for support. And usually it's just one thing that an older person wants help with at the time. We agree with professional services how we would escalate care for critical risks, such as high risk of injurious falls, moderate to severe cognitive impairment, presence of moderate to severe depression. And we can have pathways built into the tool to identify family carers and signpost them to family carer support services. So this is a comprehensive response to the needs of the older person. We follow up to measure satisfaction with process and outcome, to measure the uptake of resources, changes in health-related quality of life scores across 4 dimensions of quality of life: independence, social connection, well-being, and healthy behaviors. And then, because the tool is digitized, we generate information for individual and population health management. So a summary of the assessment can be included in a shared electronic health and care records, and data at a population level can be integrated into population health management systems. We also extract de-identified data, which goes into our global database that all researchers have access to, and to which we give access to the World Health Organization to inform person-centered policies for older people. And WHO have recognized that our tool is the only one that can provide these validated data. So I'm very proud that we contribute to the ongoing development of global policies for healthy aging through the data generated from the use of our tool. What are the benefits for individuals and populations? Well, we know from the research that at the broadest level, there are really important benefits for older people, systematically helping older people on average increase their healthy active life expectancy by about a year, tackling the huge problems that are sometimes present with aging, such as loneliness, pain, depression, reducing risks of things like injurious falls and abuse, improving health-related quality of life, and enabling older people to remain at home for longer. These are really important benefits from the systematic adoption of this approach. And for system leaders responsible for population health, we know that use of our tool in the way that I've described reduces demand for primary health care, for acute hospital care, and ultimately for long-term care and support services. We know that we can tackle health inequalities because the older people for whom use of the tool is most popular and produces the greatest benefit are those who are least well served by the current system, and whose needs can become better addressed through the use of the tool. And we know that there is a saving to the system. Independent health economists in the UK have estimated that the average benefit per older person in the UK is an absolute cost reduction of £33,000 due to the reduced need for long-term care and support. And that equates to a very big saving when the tool is used at scale. We have a phased approach to implementation because there has to, although the general case for the approach is valid and evidence-based, it has to be adapted for the local system. Every local system differs. So we have a prepare and demonstrate phase where we work with people. I'll explain a bit more about that in a minute, how we work with local stakeholders to decide how we're going to use the tool and the broad approach, how we're going to fit it into the local system. We would then demonstrate with a pilot study of up to about 1,000 older people in 1, 2, or 3 sites. And then we would move, having shown that the tool can work in the local system, to spreading, evaluating, and getting to scale. And that means there's a lot of work to be done to prepare for the use of the tool, but it's work that lays the foundations for a successful integrated care system with maximum use of personal and population data to improve outcomes. Obviously, we have to have information governance arrangements agreed as we're sharing personal information. We have to adapt our platform for the tool, which sits on a Microsoft Azure server, for the local features. We train people to use the tool with older people in a structured conversation, and these can be telephone-based or face-to-face. So we need to identify who's going to administer the tool and train them. And the people who administer the tool do not have to be health and social care qualified professionals. They can be volunteers, they can be contact center staff, they can be care assistants. And our training is accredited for international vocational training in person-centered assessment. We have to develop the data sharing systems with electronic care records and with population management systems, and we provide a project delivery support structure for these early phases of adaptation and demonstration before creating a system that's easy to spread and to scale. For the system itself, we work with local systems to agree which population of older people are going to be approached and how we would approach them. We have to map the 56 areas of potential concern to local sources of support. And for people who say, what's the point in finding out about certain things if there's nothing you can do about them, I would direct them to the work we've done in Uganda, for example, where we've developed a response system for all 56 concerns and successfully deployed the approach there. So certainly in a resource-rich country, it's possible to identify sources of support, many of which come from local voluntary and community services. We have to agree where we would need to escalate care to health and care professionals, because it's not fair on the people we train to do the initial assessment and signposting service to have to deal with issues that have to be managed by fully qualified and appropriate health and care specialists. But we have 90% of the work done at the voluntary and community level, and only 10% needs to be escalated for professional intervention, so we can use that specialist resource most effectively. We need to agree what are the systems we'll use for carer identification and referral signposting and support. We need to identify the demonstration sites. We need to decide who will do the face-to-face assessments. And we need to agree how we will share the summary report for integration into personal care records and how we will integrate data into population management systems. But all of these things we have a lot of experience in doing in different systems, and we can point to ways in which these have been introduced successfully before embarking on that preparatory work with any new local system. And we put a framework around the implementation with agreed governance and project management arrangements. So in conclusion, I'm very proud of this work because it helps me fulfill a promise I made to my mentor to address the problem of the unreported needs of older people. We found a way of doing that, and I have a burning ambition, as do my team at Age Care Technologies, to help older people across the world achieve these better outcomes, really break the mold from systems which spend a huge amount of money in care for older people but don't always address the things that really matter to them, to do that for the individual older person, for the family carer. I would love to be able to work with colleagues in Hong Kong to do this work with old people in Hong Kong through a combination of government support and provider alliances, helping to shape and develop integrated care. I think we need to everywhere break the mold of how we respond to the needs of older people. We need to break the mold in terms of how our system works together as an integrated system that all parties can contribute to improve the population health. It's been estimated that adding 1 extra quality life year on average to every American citizen would generate an economic benefit of over $50 trillion US. The prize is huge for extending healthy active life at a system level, and indeed it is essential that we adopt approaches that can achieve that at population level if we're going to have sustainable health and care systems with aging populations. And finally, an understanding of the needs of older people combined with the adoption of modern digitized technologies will help us hardwire these changes and produce the benefits that we want for individuals and for populations. I'd invite colleagues at the seminar to contact me or my founding partner, Bruce Finnemore, to discuss how we could work with you to realize some of these benefits in the context of the system in Hong Kong. I firmly believe from past experience that the brilliant leadership in government of the administrative region, combined with the talents of the providers of care and the commitment to creating a compassionate society which respects older people and delivers for them for things that matter in the context of family care. It gives us the foundation of making this work. And indeed, I'd say if we can't get this system to work in Hong Kong, I'm not sure where we could get it to work, because such is the opportunity and in this part of the world. And I very much look forward to, I hope, working with you on common purpose to break the mold in the way we care for old people, to break the mold in the way we develop our systems of care for older people, and to break the mold in the way that we use modern technology for social purpose and social benefit. Thank you so much for your attention, and I look forward to taking questions based on this presentation. Thank you very much.
Thank you, Ian, for the presentation. And we are very happy to have Ian with us here for the live Q&A section. Hello, Ian.
Hello, nice to join you.
Yeah, very happy that you're taking your time with us to respond some of the questions asked by our audience. So let's take a look on the question asked by our audience. The first question will be, given the diverse cultural and societal context in which your tool is implemented, how do you account for the respectful cultural differences and preference when addressing the needs of older people?
Yeah, well, thank you for that question. Our approach has always started from the point of view of a multicultural perspective. This isn't a methodology developed in the UK. It was developed with international partners in 50 countries around the world. And we are able to explore differences in needs
have the second question. Since you know Hong Kong for a long time, in your opinion, what are the strengths and the challenges for Hong Kong or APAC to adopt further digitalization of assessment in integrated care?
Thank you for that question. I think Hong Kong is one of the best placed societies in which to develop a strong approach to promote healthy aging. I think the challenge is to make sure that all older people, irrespective of background, income, housing, get access to the support they need to stay healthy for longer. And with the aim of achieving the goal of extending healthy active life and compressing the period of need for care prior to death. That will save the economy money. It will pay for prevention services. Indeed, it will release budget to care for people with high-end needs, as well as those with preventive care approaches. So I think Hong Kong will get it right. I was in charge of the National Plan for Intermediate Care in England, which we got most of the way towards implementing. I took it to Hong Kong. It was fully implemented in Hong Kong. I have enormous faith in the civil service in Hong Kong, in the clinical leaders, in the social care leaders, and in the partnerships between businesses in Hong Kong with social care organizations through their corporate social responsibility funds.
Yes, you mentioned about healthy for longer. I think it's definitely a common goal for our social care organization in Hong Kong to achieve this goal. So we have another question. Is there any suggestions for next step of integrated care for elderly in Hong Kong?
Well, one thing I would say is I would like our method, our approach, to be validated in a proof of concept project in Hong Kong. We know the generic offer adds 1 extra quality life year on average per older person. I'd like to see that applied in Hong Kong and tested, because that will be one contribution to promoting healthy longevity. The other 2 steps I believe are required is, one is at the base level of promoting the behavioral and environmental changes that encourage healthy longevity, and Hong Kong has addressed that. I've seen the lovely parks with the fitness equipment for older people. That's a good example of an initiative there. And the third thing is to have the advanced old age specialist services to manage people with frailty and dementia, which again is a strength in Hong Kong. But I believe the missing piece is the older people living at home who are carrying risks affecting their health, independence, well-being that are not getting reported and not getting addressed. And that's why I would like to work with colleagues in Hong Kong to see if we can address that need.
Yeah, I also look forward to see it's happening in Hong Kong. So let's explore if there is some collaboration opportunities in the future.
Very much like that to happen. That would be my key measure of success from engaging with this wonderful event that you're organizing.
Yeah, we will love the engagement too. So here we got another question. So what challenges have you encountered in implementing your approach in different healthcare systems, and how have you addressed or overcome these challenges?
Thank you. Well, the biggest challenge is to create a focus in preventive care when there is so much need to respond to the needs of people with complex care needs. And how do we shift budgets towards preventive care? In England, I had to address that challenge nationally to run and develop our national dementia strategy. We had to get an economic evaluation undertaken by the Treasury, which showed that early intervention in dementia, although it cost the health service money, saved the overall economy a huge sum of money through better care for people with dementia. So I think that is one challenge. How do we get budgets to shift towards preventive care when there is so much need to be addressed for people with already needing intensive care support for health and care services? The second thing is resistance to the transformation to a new model of care. Because if we're going to empower older people, which is what our tool does, it means it's factual that if you empower one group, you disempower another. And there is sometimes professional resistance to moving to change because that means changing the nature of their work. I think these are the 2 big challenges, to shift to a model that will best serve the needs of the whole population.
I think Hong Kong also shared the same challenge as you. So I think your answer will serve as a very good reference for us to tackle the challenges.
Thank you.
And we have one more question to you. So that is, how do you ensure the personal data collected through the tool is securely managed and protected, especially considering the sensitivity of the information shared by older individuals?
And it's a very good question. We now spend, the highest element of our spend as a business is on data protection and compliance. So we have to work to the best national and international standards for data protection. And as the world moves ever more digital, ever more into the sharing of information, that becomes increasingly important. And we have to keep pace with that change, and we have to be on top of data compliance regulations. And actually, during the preparatory phase for introducing our methods into any system, we first make sure that all the data compliance, data security, data sharing arrangements are in place and that they are robust. And there's a set of principles around how you can do that you only use information where you need to, and many other things to do with that. It's a very important question, and it requires a real commitment to data security, data protection, confidentiality, and consent.
Okay. Thank you very much, Ian. Thank you for taking your time here. Your presentation is very inspiring, and your advice will be very insightful to us in Hong Kong too. Thank you very much.
That's very kind of you. Thank you so much. It's been a delight to contribute to this wonderful event. Thank you very much.
Thank you. Please keep in touch. Goodbye.
Bye-bye.